but we'll go ahead and kick things off here. Welcome today to our SOAR web series, Preventing the Primary Caesarean and the Role of Intermittent Auscultation. I'm Jamie Cabrera. I'm the Executive Director of the Colorado Perinatal Care Quality Collaborative, and we're so thrilled you're here to join us today for this wonderful education opportunity. Next slide. We're gonna just cover some logistics first. Want to alert everybody that this call is being recorded, so if you have issues with that, unfortunately, you're welcome to drop off and watch the recording later, but we do want to alert everyone that if you have questions or chats, any conversation today will be recorded and shared for learning. Please stay muted during the presentation and use our chat box or Q&A, whichever is more comfortable for you. We'll keep our eyes on that today. No need to wait. You can chat your questions in and we'll make sure that the presenters are alerted of them and can address those by the end of the session today. We ask that you please complete the evaluation survey. We'll send that in a link right after we finish. It is super helpful for you to provide input about the content, how it was presented, and its usefulness in your daily tasks as we make constant modifications to the things that we share with you in the true form of quality improvement. And so we'd like to kick off today. If you would please chat in your name, your role, and your organization where you work, or maybe what brings you to the space. We would love to get a better sense of who's on the call and how this content that you see today, you might be able to use that and directly apply it to your day-to-day job role. Next slide. All right, I see chats coming in, thanks. And again, for those who might have just joined, throw your name, your role, and maybe where you work into the chat so we can get things kicked off. So hi Bree, hi Taryn. All right, we're gonna start things with a couple polling questions. We actually have 3 today. So Callie's gonna go ahead and launch the first one. While you're chatting in your name, your role, and where you work, we'd also love to get a little bit better understanding of your current experience with IA. So Callie, go ahead and launch that first poll. We're just wanting to get a sense of how many of you currently have an IA policy where you work and are referencing and using that IA policy. So you'll see that poll there. It should pop up right in the front of your screen, and we'll give you just a few seconds there. Just a simple yes or no. Do you currently use an IA policy in your practice? All right, it looks like we still have some votes coming in. Give you all just a few more seconds here. Quick yes or no for us would be really helpful to gauge what you're using in your practice. All right, just a couple more seconds. Okay, Kelly, let's go ahead and end that poll, and if you'd share the results for us. All right, it looks like about 83% of the group have and are using currently an IA policy. Awesome. All right, let's launch the second one, Callie. All right. So many of you are using or have an IA policy to reference, and now we're curious about your comfort level using IA. So we're just gauging this low, medium, and high. Again, your input here would be so valuable for our experts as they share some more information to really get a better understanding of where everyone's at. So go ahead and take a few seconds there and feel free to let us know what your comfort level is using IA. Okay, we're going to leave it open for just a few more seconds. All right, if you haven't voted, we're about to close that poll, so get your answers in, low, medium, or high comfort level using IA currently. All right, Callie, let's go ahead and see what the audience says. Okay, so kind of mixed, right? Looks like 40% high, 20% medium, and 40% low. So hopefully you'll learn a lot today and we'll be able to increase that comfort level after the next 45 minutes. Okay, Callie, and our final question for the audience. Go ahead and launch that. All right, this is a true false. intermittent auscultation has similar outcomes to continuous fetal monitoring. All right, so go ahead and let us know what you think. All right, we got it a little better than half of you. We'll give you a few more seconds here. All right, another few seconds before we close up the poll. Okay, Callie, let us know what the group says. All right, so looks like about 86% of you said true. So I'm sure Amy and Eliza will be happy to confirm that answer as they walk through more information and details about the IA process. All right, we're going to go ahead and close all the polls. And without further ado, I would love to introduce you to Eliza Burrell, certified nurse midwife working at Denver Health in a number of different areas. Hi, Eliza. And Amy Dempsey, RNC MSN, working at Lutheran Medical Center with the OB clinical practice as a specialist. So we're thrilled to have them both here today. And I will go ahead and pass on the mic to Eliza and Amy to get us kicked off.
Perfect. Well, welcome everyone.
Good morning. Can't hear Amy.
Amy, you're on mute.
Let's try that. All right. We're excited to talk to you about one of our favorite topics of intermittent auscultation and how we think it may be able to positively impact our vaginal delivery rates and support normal physiologic birth. So today's objectives are to understand the evidence behind IA, the risks and benefits of it, the limitations, who it's appropriate to use IA with, identify the interventions in the presence of indeterminate findings, identify criteria for discontinuing IA, and documentation. So we have a lot to cover. We'll jump right in. We wanted to give a little background onto how we think this connects to reduction of our NTSB cesarean birth rates. And we wanted to point out that this is data that's been collected in our cohort over time. And you'll see that there's three big buckets that really impact our NTSB rates: arrest of descent, arrest of dilation, and then fetal intolerance of labor. And look at this. It is just over time, percentage continues to increase. And we just see this purple bar graph down at the bottom. This is our fetal intolerance of labor. And you'll see that it just continues to rise over time. And one way that we can, here's another illustration of that. Fetal intolerance of labor really continues to be one of the primary reasons why we are moving to cesarean delivery in our primate patient population. So one way that we can impact that is to make sure we're using intermittent auscultation appropriately. If we don't have patients continuously monitored, we are less likely to move to cesarean delivery for fetal intolerance of labor. And so let's look at who are appropriate candidates for intermittent auscultation and how can we use this wisely. So a little bit about the background of fetal monitoring. Fetal heart rate monitoring is a crucial part of monitoring the well-being of a fetus during labor. We believe that, we know that the goal of fetal monitoring is to assess fetal well-being and detect any abnormalities which might indicate fetal intolerance of labor and help us do appropriate intrauterine resuscitation so that we can have an ideal outcome. All right. And trigger happy here. All right, Eliza, I think you're going to take over from, well, I think you're going to take over in just a second. I'll keep going here. There's 4 ways to monitor the fetal heart rate. Intermittent auscultation, which is what we're going to talk about, continuous fetal monitoring, and we have 2 ways to do that, either external or internal. Everybody on the call is familiar with those.
And so this is a Pinard horn, and I don't know how many of you have ever used one of these. I've only ever seen one. I've never used one in clinical practice, but they're used widely in low resource settings and also in out of hospital birth, particularly in, like the clinics. A lot of out of hospital birth workers that I know find it hard during labor because of the noises that the birthing person makes to hear with the Pinard horn. It has to be incredibly quiet. So mostly, next slide, Amy, you see a fetoscope also is easier than the Pinard horn, but yet next slide, mostly what we see is the Doppler. And that's what most of us are familiar with who are using intermittent auscultation in the hospital setting. Yeah, go ahead, Amy. Thank you. Next slide. Yes, it's the oldest method of auscultation. In fact, people used to just listen with their ears once the fetus was full term, and you could put your ear against the belly and hear the fetal heart. But electronic fetal monitoring was developed in the 1950s, and it was introduced and with widespread excitement into hospital settings before it was really tested as a screening tool. And so you can see how every decade it has gone up, and even into the 2010s and 20s, it remains at over 85%, 90% of utilization across labor and delivery units in the United States. Next slide.
My clicker is so picky. I'll try to advance one at a time.
So going back to an ACOG July 2009, we're going to take a look at the evidence, because the question is why are we using a tool that we now have so much evidence that shows us that there's not only controversy, but there's data to support that it increases cesarean section rate. So our poll question was actually kind of a trick question. So yes, particularly the one about, is it equivalent outcomes to continuous fetal monitoring in terms of moms and babies? And that the true answer to that is no. Intermittent auscultation actually, so it's false. It has a increase in harm. Continuous fetal monitoring has an increase in harm. And so intermittent auscultation in the appropriate patient is going to produce better outcomes. And that's what we're hoping to, tackle by introducing these into our units and having utilization, is that we are going to be able to impact for the low risk patient cesarean sections that are done for fetal intolerance of labor. So, ACOG, even back in 2009, had a statement that was so strong that we shouldn't be using it. So I'll jump right into some of the evidence, because I feel like that is helpful. And at my institution, I'll tell you, when I started at Denver Health in 2006, nobody was getting intermittent auscultation. Everyone had continuous fetal monitoring. And we have successfully rolled out and utilized this method ever since 2006 with really great results. And there was a ton of challenges. So if you're facing challenges within your own institution for implementation or greater utilization, let me tell you, it's possible. And the greatest thing about having all of this evidence that has not changed over time is that it really supports quality and outcomes and is your biggest tool for having these conversations. So 1976, the first RCT was done. Actually, Denver Health participated in this one with Dr. Haverkamp. The N was pretty low. However, it was with high-risk patients. And so you can see that why it was high-risk patients in the study group was because as this was being rolled out, everyone was so excited that this was going to be able to, really improve outcomes. Continuous fetal monitoring was going to make a really big difference, because prior to this technology, we were using intermittent auscultation. And so they really included high-risk patients who are at risk for adverse outcomes. And there was an increased cesarean section rate in the continuous fetal monitoring group. No difference in neonatal death, APGAR scores, blood gases, or other neonatal morbidity or mortality, and the perinatal rates were the same. And so this trial caused a huge uproar within the community because nobody believed it. They were like, no way, this is our deus ex machina, the God in the machine. There's editorials written about this in many of the obstetrical journals. They just couldn't believe it. Next slide, please. So after the Haverkamp trial came a slew of other trials. The Levino trial, is that one before this one, Amy? This slide back. What was after Haverkamp? Dublin. Okay. Dublin trial produced a ton of study results, not only around intermittent auscultation, but around active management of labor and other data that still drives practice today. But this is a big N, 12,000, almost 13,000, birthing people, low and high risk pregnancies combined. And again, they found the same thing, higher C-section rate and assisted deliveries with continuous monitoring, and then no difference in APGARs, neonatal resuscitation, NICU admissions. And I will point out this increased rate of neonatal seizures in the intermittent auscultation group persists across studies. And this is interesting because this is not seizures related to HIE. So these were very benign seizures that, after talking over the years with many, NICU providers, pediatricians, obstetricians, nurses, and other midwives regarding this, the only thing that I can think that this directly relates to, because a lot of the data and studies don't get into this specific outcome, is that there was use of high dose Pitocin in many of these trials, and these patients were included in these studies, high and low risk. So there wasn't this category of you had to be off Pitocin, off epidurals, not have any risk factors to get IA. Everybody got it. And so part of the thinking around this, and this is just sort of a theory, is that this is related to water intoxication and there being a disruption from the babies getting, basically the moms getting too much water, too much Pitocin, and then having seizures related to that water intoxication being passed on to the baby, disrupting the sodium, potassium, and all of their, metabolites or metabolic issues. So I'm not entirely certain about that, but the take-home message is here, we don't focus on that because otherwise the long-term perinatal outcomes are the same, but I always usually get a question about it, so I included that there. Next slide, please. So then we have the Levino trial. This was a big perspective comparison, and this was all low-risk individuals, almost 35,000 women and birthing people. So this is, and these were all term babies, and this was a funny little methodology because it was, you were allocated to universal or selective monitoring depending on the day of the week that you came into the hospital. But nonetheless, they found the same thing, increase in cesarean section rate by almost 20% and in across the board in all of these studies, and then no difference in perinatal outcomes. Next slide. So then after all of these studies were coming out, and there was a lot more, but I've chosen to focus on some of the best studies, the most well-done studies. There's the Thacker meta-analysis that looked at 12 of these RCTs, combined them, and this was between 1966 and 1944, over 58,000, almost 59,000 birthing people, high and low risk across the globe, and found yet again the same results, increased C-section and associated morbidities. And when we talk about associated morbidities, I think it's important to also recognize that in the studies, a lot of it has to do with wound infections or embolus or infection, bleeding for these patients. But there's also the associated morbidity that impacts optimality. And it's really important to mention that because, as a lot of us know in our job, that if you have a cesarean section, often what is disrupted is that initial golden hour with the baby, and the subsequent impact of that can be profound. Many of our institutions are doing skin to skin in the operating room if it's not an emergent situation, but that definitely impacts bonding, breastfeeding when there's that separation. And so these are associated morbidities and disruptions in optimality as well. Next slide. So then we've got our Cochrane review, and the Cochrane selected the very same trials that the Thacker meta-analysis selected. And Cochrane is very highly selective. These studies have to be good, of high quality for Cochrane to include them. Again, though, most of these trials were not well done because only a few of them were RCTs, as most RCTs are very hard to do well with pregnant people, as we all know. So the one that was the best done was the Dublin trial. And that is the one that really probably influenced many of these results. So no difference in babies who died during or shortly after birth, no differences in CP, or now as we call it HIE, and neonatal seizures were rare, but slightly more in the IA group. Next slide. So yeah, thank you. This leads us to a conclusion that we've known for a long time, but the only clinically significant benefit from the routine use of continuous monitoring was the reduction in these neonatal seizures that were self-limiting and had no long-term sequelae. The rates of intrapartum and neonatal deaths related to CP and HIE were similar, whether the fetal heart rate was monitored either continuously or intermittently. Next slide. And so even the United States Preventative Services Task Force in 1996 released a very strong, recommendation that we should not be using this technology, and this should be considered an intervention, and an intervention that should be used wisely, and it should not be used in low risk women and birthing people. So this language persists, and I put our various organizations' clinical bulletins and position statements on intermittent auscultation because it is interesting to look at the difference and strength of languaging around utilization. So ACNM really supports utilization of intermittent auscultation, same with AWAN and other nursing organizations. However, as you'll see as we come forward in the slides a little bit, is that the obstetrical languaging is not quite as strong. So moving on, next slide, please. So continuous fetal monitoring, this is the crux here, is that it's overused in the low risk population, and we are overly relying on a poor screening tool. So we have across public health, when we look at screening tools for anything, we look at their validity and their reliability to determine whether or not it's good at doing what we hope it's going to do. And so as a lot of you know, it's really a 99% false positive rate for predicting CP or HIE, which lets us know, as we've all seen, when we're really concerned about a baby in labor and we're seeing certain characteristics on the fetal monitor, and we make a decision to proceed with cesarean section, and out comes a screaming baby with normal gases and perfect APGARs. And we're like, goodness, we were so worried about that baby. And then we have a great outcome and we think, gosh, we probably didn't need to do that C-section at that time. So in that regard, it's just not the best tool. It lets us know, with its validity, is very poor at detecting fetal asphyxia and hypoxia, but it's great at telling us we have a well-oxygenated baby, which is wonderful. And I think that's the part of it that we really all rely on and love to see, those indicators. And then it's also got low reliability, meaning we can't all come to consensus about how to interpret findings. We've tried our best with standardizing interpretations and category systems, but nonetheless, these differences persist across institutions, within institutions, across provider groups. And this is really what we're trying to narrow, this gap. So we can also talk about some of the legal issues, but this is basically leads us to this slide, that it does have benefits. So it's not to throw the baby out with the bathwater, and the benefits is that we can identify early signs of developing hypoxia, particularly in those patients that are high risk for this. And we talked about it being an excellent predictor of normally oxygenated fetus. And then it does allow us to determine what's going on with the baby in concert with the contractions, which is something that we don't have the benefit of doing with intermittent auscultation. Okay. We talked about limitations already, so moving on. Intermittent auscultation, we also talked about the benefits, because the limitations of continuous fetal monitoring are the very benefits of intermittent auscultation. And I'll just focus on a couple more here in this list, is that it definitely increases support for normal physiologic birth. So it increases the mobility for the birthing person. They can ambulate, use the tub, have hydrotherapy, change their positions, and be more comfortable. It also decreases the use of analgesia and anesthesia in labor. And even if it delays it, if the birthing person is intending to use medicine, if you're tethered to the bed and you can't move and you have no other options then, and there's not mobile monitoring. We all mostly have mobile telemetry now in our units, but historically, and still some places do not have those because they're very expensive. It definitely limits your mobility, which then increases pain. And it fosters a more continuous labor support mentality and model of having the nursing staff and the provider staff and midwives at the bedside and not out at central looking at centralized monitoring, but actually being at the bedside, with the patient and family. And it focuses on the birthing individual, not the machine. So this is something that's discussed a lot in a lot of the literature, and also facilitates alternative birth positions, out of bed, squatting, hands and knees, all of these that where continuous fetal monitoring is very difficult when a woman is in, or a birthing person is in hands and knees, leaning over on the birth ball. It's hard to get the fetal monitor to pick up the heart rate. So limitations is that we don't have great frequency of auscultation. The methodology and evidence around the best practice for this is lacking. And what we've come up with is basically ranges, which we'll take a peek at in a minute from our various professional organizations. The take-home message here is that it didn't matter with what methodology a study was using, they all produced the same results. And so some were listening every hour, some were listening every 15, every 30, and some were listening every 2 hours, much earlier on in the studies. And so it all produced the same outcome. So we've decided on ranges that, seem either conservative, if that's the environment that you're in, people will default to a more conservative auscultation methodology, or depending on where you are practicing, maybe have a wider margin for auscultation. We're going to go through that, and I'll talk to you about, I work at Denver Health where we use the outer margins for auscultation, but any auscultation is better than none. So whether you're using a high-risk protocol or a low-risk protocol, it's still good to just, as you're rolling it out, if you're not using it and it makes your team more comfortable to do a more frequent auscultation, then I would encourage you to do that, although there are some drawbacks to that, which I'll talk about. So you could miss an acute and sustained bradycardia. What I'll say about this, particularly also in second stage, where there's a 5 versus 15-minute auscultation frequency, is that, this is always possible. I mean, this is possible when, patients get off the monitor to go to the bathroom, whether they're on continuous or whatnot. Yes, we could miss this. But remember that the outcomes produced are the same. And so if we're monitoring in the correct patient, that this is something that is exceptionally rare. We've looked at our data every year at Denver Health on intermittent auscultation, and we auscultate every 15 minutes in the second stage of labor, and we have not had an increase in NICU admissions, low APGAR scores. And so, but this definitely takes some comfort and getting used to. Difficult to assess variability. So we really cannot reliably assess variability in the way that we describe variability according to the NICHD guidelines. So you'll hear sometimes people say, oh, the baby's got great variability. Mostly we can hear that because our ears are trained to hear what good variability sounds like, but we cannot comment or document on this because it's a criteria that is established for continuous fetal monitoring and not for intermittent auscultation. And then the periodicity of decelerations cannot be determined reliably. So even though we think we hear a decrease or a deceleration, we can't reliably say, oh, that's an early or that's a variable or a late deceleration. Limitations, staffing matrix, we're going to talk a little bit about that as we move along. And then it really requires unit education, commitment, and support for sustained use. Otherwise, you will see that there's a tendency to move back towards the continuous monitor. And then you have, I'm trying to think of the name for that. You have the normative, my brain is not working right now to get to that concept. So I'll move on anyway. And then there's no permanent record of the fetal heart rate, which makes some people nervous, but I think that that is potentially a good thing since there's so much in courts of law. There's a lot of different experts weighing in when cases go to trial on what's going on the fetal heart rate. So if you are able to take a pulse or listen to heart and lungs and document that, it will be upheld just as your auscultation will be if you follow your unit policy. Next slide. So I always throw this one in because these two go together, intermittent auscultation and supportive care during labor all go together. And many of us are aware that continuous labor support produces incredible outcomes, and that I still question to this day with all of this data why more hospital systems do not have doulas on staff in order to help facilitate support of birthing people, because this persists even when epidural use is involved. So it doesn't have to be with just natural, births without the use of anesthesia. Next slide. And then, so here's the Canadians, they like to say, the OBs in Canada, that it is the preferred method. And again, ACOG, we may be able to evaluate it by auscultation or EFM, like they're equal, but they aren't really equal. So next slide. And again, here's ACOG in 2009. Either option is acceptable in a patient without complications. And this languaging still has not been updated to this day until very recently, and not so much even in ACOG's fetal monitoring clinical bulletins, but we have linked in another slide down the way some of ACOG's languaging on limiting interventions in normal birth. And that is where they have their strongest languaging around using intermittent auscultation. Next slide. And then no talk would be good without ethical principles. And I think intermittent auscultation hits all of these, that we do see many patients coming in and wanting this, but many do not, but that we do educate and have shared decision-making with our patients and families, and that they are allowed to have personal liberty and self-determination even around their birth experience. If we are attempting to be beneficent, then we want to do good and use the best evidence we have to support quality and good, safe outcomes, and to do no harm, non-maleficence, to prevent harm. And then justice, fair or equal treatment of individuals. This is a big one, and it was a big one when we first started this at Denver Health, because we had, and still to this day, have a large population who are not, up on the research and coming in with a birth plan and or a doula and saying, I do or don't want monitoring, and I want to avoid this. They may know they want an unmedicated birth, but I'd say the vast majority of our patients that come in, don't have that. And it was really important when we were rolling this out that we made it available and accessible to all birthing people that came into our population, and not just midwifery patients or midwifery clients coming in with a birth plan. And then the veracity is the duty to tell the truth, where we're not having, I think, on a regular basis, these conversations in the clinic or antenatally, or even when patients arrive to the labor and delivery unit, that it's just expected the monitors go on, and patients don't really know that there's a potential for harm with this type of monitoring. Next slide. So what to do? Use monitoring appropriately. Use intermittent auscultation as the standard for low-risk birthing people in your institution, and have an agreed upon criteria for low risk, which is a little bit debated in the literature, and as you'll see, varies from institution to institution a little bit, but have an agreed upon criteria, develop guidelines, and then have a very structured and safe criteria for moving to intermittent auscultation to continuous when there's risk factors that develop throughout the course of the labor. And then work towards standardizing of EFM pattern identification and appropriate responses, which is still something that continues to be and pose a challenge within the care of women in labor. So who's the appropriate candidate? At Denver Health, we also, I think, are linking both of our guidelines from Amy's institution and from Denver Health as well for you guys. So you can use them if you want to bring them back to your institutions to either make adaptations to your own guidelines or roll out a work group to develop your own. So we have used the term reassuring fetal heart rate strip on admission, which I know is debatable, the usage of the word reassuring. But we decided to not use a category system, which for determining who is a candidate for this, because we found that it limited who would be a candidate for using it and creating a barrier. So you may find at your institution in many places that is going to be required ACNM, and I believe Amy A1 says category 1 coming in. Is that correct?
I'm not sure that they did say that. But
Okay.
I can look that
I
up.
definitely know ACNM, our organization for the American College of Nurse Midwives, does. And so we just define it in our guideline. You'll see we say normal baseline, absence of persistent decelerations, and presence of moderate variability. And the reason that we did that was because occasionally someone will come in and they'll be on their back end triage, or they'll, have something episodic, a deceleration that is quite common in labor, but does not at all correlate with there being concern for fetal well-being or lack of oxygen. And we found that then if there was one little variable deceleration, then somebody would just get put on continuous monitoring for the remainder of their time in labor. So we really wanted to eliminate that barrier. However, if we do notice that there's decelerations, we do have to be able to say that they aren't persistent. So that languaging is really specific in our guideline. 36 weeks or greater, a lot of places it's 37, Vertex, singleton pregnancies. And then we developed our own maternal and fetal exclusionary factors, which you'll be able to see. And then no interpartum risk factors. Next slide. Amy, it's you.
Yeah, so I think in answer to your question, I just quickly glanced, but I did want to point out that A1 has their 3rd edition of fetal heart rate auscultation. It's a practice monograph, and it really does a great job of going over some of this history, the benefits, identifying who's appropriate, and using the technique. And it does not cost much. Members, it may even be free. And then I also wanted to mention the guidelines for perinatal care. They're on their 8th edition, and this is the American Academy of Pediatrics and ACOG book that they publish. And it specifically addresses intermittent auscultation. And in terms of having a category or a reassuring, really, my recollection is that they don't go into defining that, because there is strong evidence that when you're picking the appropriate patient population, you don't even need to have a fetal monitor tracing to be able to just move right to IA. Now, with that said, most institutions want that reassurance, and they feel more confident using IA when they actually have a monitor tracing on admission. So some of those processes really require some collaboration and some group work to come up with what's best for your institution. So my recollection is that A1 doesn't even say what that criteria is. They just jump right into IA. So ACOG actually did try to define low risk for us and make it less nebulous. I think in doing so, they probably limited the pool of patients that qualify. So that was, it was helpful that they tried to define it, but then it was also a little disappointing because some of these patients may not have been on our list for our policy. At Lutheran, we actually have now an SDL health policy. It's 8 sites that all agreed, which was a challenging feat, let me tell you, to come up with this policy that we could all agree upon. But here are the definitions in the blue book that I just mentioned. They need to be term, and they need to have absence of meconium staining, which to me, this was disappointing. So I think a lot of patients actually are probably a little later in pregnancy, past 40 weeks, and have meconium, and they want to have intermittent auscultation. And so one way around this is to delay when you break a patient's bag of water. You can wait until delivery, then you never know what color their fluid is. And I think that's actually a strategy that a lot of my midwives use. if a patient has intrapartum bleeding or abnormal undetermined fetal test results before birth, no increased risk of developing fetal acidemia. So that is a little bit vague, but I do think IUCR, or if we want to use a fetal growth restriction that's like less than 3%. Some places will use 10%, but those are some of the things that each institution needs to determine. A patient with a previous uterine scar is obviously going to be high risk. Diabetes, we actually did some talk around this and decided that if they were managed with insulin, that would qualify. Otherwise, if they were diet, that did not put them on the list of exclusion. And then hypertensive disease. Oxytocin, the need for oxytocin put them on a high risk. And then there were some other additional considerations. 6 centimeters is used for active phase of labor definition, whereas 4 centimeters is usually used for when patients are admitted in active labor. And so some of those conversations need to be a part of each institution. So defining reassuring, we've already touched on that. And I think that most of us could agree that moderate variability is really a common factor with a normal baseline. I wanted to just point out that category 1 does not require acceleration. So really an NST is not necessary. The active NST. These are certainly some of the decisions that each institution needs to mull over and come to consensus on when developing a policy. Right now, A1 is requiring continuous fetal monitoring for misoprostol. So that would rule out IA as an option for miso. I do think that there's some conversation that happens with each individual patient scenario, but at Lutheran, we'll put the patient on continuous monitoring for misoprostol, and then if they go into active labor and they don't need continued oxytocin, then we'll go back to an IA policy or IA practice. So working out some of those details, like I've already given you my little hint on meconium, and we do IA with, we allow IA with fentanyl or Stadol, but I do know that's probably system specific. And then oligohydramnios coming up with some good parameters for how to define that, and if that is included in your IA policy as well, as either an inclusion or an exclusion criteria. I love that our organizations have now tried to give us some guidance as to how frequently we should be doing IA, and we listed them here. Obviously, it would be nice if they were all in agreement, but at least they're trying to give us some guidance, and I think that each institution just needs to determine what they want to follow. And then I wanted to talk a little bit about how. Up until very recently, we were recommending that you auscultate in between contractions, and that in this latest edition of the 3rd edition of the fetal heart rate auscultation monograph, that recently changed in terms of A1. ACNM may be still a little bit different, but I just thought we would go over how to do it so that we can gain some confidence. Obviously, staff education is huge because, like Eliza mentioned, if nurses are most comfortable and familiar with continuous monitoring, that will be their default. And as soon as they don't feel confidence in what they're hearing, they will refer back to their level of confidence, which is in continuous monitoring. I think that some of my newer nurses who've been taught now to do both have a little bit more confidence with this. Yeah. I think my older nurses who've been doing this for decades gosh, it's just been a little bit of a challenge for them to gain confidence using it. So obviously you need to have a watch or a clock close by so that you can actually count your beats. It's helpful to use. I noticed that the Doppler picture that we chose was showing the beats per minute on it, and that readout is really actually very helpful for confirming what you're hearing. We talked about a 20-minute strip prior to initiating. I've already pointed out that the literature doesn't support that that improves outcomes, but I do think most hospitals have some kind of policy like that. It's helpful to do your Leopold's maneuvers so that you know where the best place is to hear your fetal heart rate. Place your Doppler on maternal abdomen. And this says auscultate between contractions for 60 seconds and then 60 seconds after a contraction. I have really encouraged my nurses not to do it during a contraction, but actually at the end to make sure it's coming up to baseline. If we listen during contractions, we're going to hear variables. And then we're going to be faced with the decision of what to do with what we're hearing. And so I think that if we can try to stick with the policy and avoid times when we know that we're going to hear variables, it's going to lessen the conflict within ourselves as to what to do with that information. There's obviously lots of different ways to count. You can do 5-second increments. You can listen for a full 60 seconds. You can listen for 30 seconds and then multiply by 2. You can listen for 15 seconds and multiply by 4. It's really essential that we know what our maternal pulse is so that we avoid signal ambiguity. And we also want to know, are we hearing the baby move? Is mom feeling the baby move? Those are signs of fetal well-being. And then documentation. I took a picture directly out of the fetal or the A1 monograph so that we could look at it. It says, determine fetal heart rate baseline between contractions, listen for at least 30 seconds. Assess the fetal heart rate for the latter part of the contraction and after uterine contraction for at least 15 to 30 seconds to detect periodic changes. I thought that languaging was helpful. So what do we do if we are hearing decreases in heart rate that are concerning? Well, we don't need to automatically go back to continuous monitoring. And I just really want to stress that. I really, we've gone over this a lot with my nursing staff. How about just increase our frequency? How about just do intrauterine resuscitation that we would do if we had her on the monitor? Like, let's change her position. Give her a fluid bolus, let's have her drink some fluid. If those patterns persist with our increased frequency, then let's notify the provider and come up with a plan. One thing that we've done at Lutheran, which I think has been really helpful, is we now have birthing suites within our labor unit. We have 2 of them, and they don't have fetal monitors in them. And patients can't just be put right back on the monitor. We have to just use these techniques. We have an opportunity, I think we built into our policy, we could put them back on the monitor once, see what's actually happening with a visual representation of a tracing, but if they need to be continuously monitored, then they need to be transferred to one of our other labor and delivery rooms. And that's really helped increase the confidence of our nursing staff. When patients want to be delivered in these rooms and they're committed to it, they're going to be less, what's the word? they are going to have more of an opinion about being put on the fetal monitor, and they're going to really, shared decision making becomes really important. And it really increases the confidence of continuing with intermittent auscultation, even when you hear decreases. Is it going back to baseline? Are we able to document that we are at a normal baseline range in between contractions? Then that's really what we want to be hearing. So when to move to EFM? ACOG was kind enough to give us some direction on this in their 8th edition of the book. Frank bleeding, that's not bloody show. Meconium, does mom have a fever? Do we have persistent bradycardia or tachycardia? Are we hearing an abnormal rhythm? Persistent V cells even after position changes and fluid bolus? Do we have uterine tachysystole, which is a little bit harder to determine with palpation? It's still on the list. And does our acuity of our unit dictate that we just really can't be in the room doing IA at the defined intervals? And that might be a reason to go back to continuous monitoring if we need to depend on central surveillance. Is there severe persistent hypertension or hypotension? Does mom now want an epidural analgesia? Then that would lead us to EFM. And then if we need to augment with Pitocin, that would certainly be a reason. So I've done a little bit of legal review, and I really feel like actually following an IA policy is really easy to defend, saying this is the standard of care, and they followed it. And they followed their documentation standards and entered their fetal heart rate at the defined periods. If they're following their policy, it's really easy to defend. Numerous cases have actually been upheld with IA as an acceptable standard, and I think if we're using good clinical decision making,
I think I take over here, and I realize we're at our time. And so we're pretty much near the end here. And hopefully you all have some good, juicy information here to either take back to your units or your interdisciplinary team. So this really is a work of culture change and sustainability that is 100% doable. And really finding champions and then what your barriers are, using these stepwise approaches and getting together, coming up with your guidelines, following them, and then educating and continued education. Nursing ratios is, you're going to have to decide for your institution what works best. At Denver Health, we're 2-to-1, and some of the literature really speaks only to a 1-to-1 ratio for intermittent auscultation. We viewed it as a barrier, and so we ignored that basically. So I think, are we at the end? Next slide. This one, it's a gateway to optimality and turns out decreasing cesarean sections. So
I love this. This lecture was so timely. Today we have a patient on my unit who just had a successful TOLAC, who's now a VBAC, and her first cesarean delivery was for fetal intolerance of labor, and I'll be darned if we didn't diagnose her with an accreta, which was so disappointing. There are risks with cesarean deliveries, and preventing the first one is really key. I think one way to do that is to have a really strong IA policy and follow it.
Yeah. And Amy and Eliza, thank you. I know we only have a minute or so left and want to make sure if folks have questions, they can chat those in or raise your hand and we can get you off mute. A few folks have messaged us that they had to hop off and thanked you, and I would thank you. Great information. Callie put in the chat some links to some of the resources that Amy and Eliza mentioned today, and also a sample of a Denver Health policy surrounding this. So if there are resources out there, if you have questions, please reach out to us, info@cpcqc.org, and we'll share all of these resources with all of you. The recording from today and the slides we can share. Somebody did ask that question if they could share with their unit and their staff, and absolutely, I think the more information that we can disseminate so that folks have that, the education materials, the reference guides, tools that they might need to really implement this in your practice, we're here to support you. So I'll open up really quickly before we sign off for any questions in the chat for Amy and Eliza. All right. And as we wrap up as well, Callie is going to ensure that everybody gets a link to the evaluation survey from today. Your input, as I mentioned before, is super valuable. It helps us to determine, what worked well and what we might want to modify, that we can share tools and resources as this work continues. So I just want to say another thank you to Amy and Eliza. This was great. A lot of really good information here, and we will get the resources out to everybody. And thank you all so much for joining us. Have a great
you guys. And I'm happy to, if you want to share my Denver Health email as well, and to field questions that might come up.
Perfect. We'll send a follow-up email to everyone that was in attendance today with the links to the recording, the slides, and all of the resources and your contact info as well.
Okay.
Thank you.
Thank you.
Perfect. Everyone.
Thanks, everyone. Callie, we can leave that. Looks like,
It's just us now.
yeah, it looks like it's just us. I was going to say we can just take a quick look at the low response on the poll, which is typical, but strongly agree for the information was helpful. They're confident they can apply this to their practice. They have the resources they need to do the work around this topic and are clear on the role they play in applying this information. So that's positive.
Good. Did it go okay?
Yeah, I think so. It's interesting because we, in this virtual world, like it's so hard to engage audiences. Like I like to see people's faces. I like to see how they're reacting. And we've been struggling a little on all of our information education series and learning sessions, is like, we try to be like, okay, chat it in, whatever. And it's just not the same as, when we used to get in person and be able to really great conversation about this. But it looked like positive responses. People were thankful, sending messages, and a few participated in the poll with a good response. So they did ask for sharing. And so sometimes, the schedules, they couldn't get on the call, but we'll share all the info.
Yeah, I think that's important, because having the resources is really critical to be able to.
Yeah. Okay. And we can link to our website updates have been a little slower because we're working on kind of revamping things to make it more of like a resource. But Callie and I can connect with Megan on our team to get the recording or any links to stuff up online as well. So yeah.
Okay, great. Thanks, you guys.
Thank you. We can without you, for real. It's amazing. So thank you for your time.
So excited. It's such important work. So thanks for all you do.
I agree. Awesome. Okay. Thanks, Eliza. We'll talk to you soon.
Bye.
Bye.